So thank you so much. Thank you so much, everyone, for attending today's session. And we are so happy to have you in this session. May I give this opportunity for everyone to introduce her or himself. May I request that we request Nonsigele Lontuli to introduce yourself.
Hello, everyone. My name is Nonsigele Lontuli from RFM Palliative Care Nurse. Thank you.
Thank you so much, Ntuli, for joining us today. Are you alone there?
Yes.
Right. May I request...
apologies on that.
Okay. May I request Tandazile to introduce yourself and your team?
Afternoon, everyone. It's Tandazile Smelane, Palliative Care Nurse from Manzini Hospital. With me here is Enizwane, and the others were also dragged into the session, but I think they'll be joining as individuals. I think they'll introduce themselves.
Okay.
Yeah.
Yes, they can introduce themselves. Yes, they can unmute so that we can hear them when they introduce. Hello, Tandazile.
Hi, Sandile. Sorry.
Yes, you may unmute so that we can hear them when they introduce themselves.
I think they'll be using their gadgets. We are in a different office, and I think Nana. Let me just check with Nana what's happening. They're in a different office.
But they have yet not logged in, so maybe if you can request them to be in the same room with you.
No, I don't think it's possible now.
Yeah, because they are not here.
Okay, let me just call them. Then we'll send on the comments.
Okay, thank you.
Thank you.
May we request Gameta to introduce herself?
Good afternoon, team. I'm Zota Kamenza, working for Eswatini Hospice at home. Thank you.
Thank you. Mr. Villa?
Good afternoon, colleagues. I'm William Villa from Lubombo Referral Hospital. It's a pleasure once again to be with the team in this session.
Thank you so much. We are happy that today we are here on this platform and again to continue with our session. May I request the team from Hospice to introduce themselves?
Hi everyone, my name is Bonges Melane with the Hospice team. Thank you.
Thank you.
Good evening, colleagues. My name is Nonduduzo Chani. I'm also with the Hospice team.
Good afternoon, colleagues. My name is Pius Poy. I'm here at Hospice at home.
Okay. Thank you so much. May I give Trustee Mata the opportunity to greet the team and introduce yourself? Mbata, can you introduce yourself?
Oh. Morning, colleagues. I'm Trustee Mbata at SANU.
Thank you, sister. Portia Damini. Portia Damini Sope. Portia, can you introduce yourself? But I said that you have not logged in with your microphone. If you are joining with your cell phone, there's a headset at the left of the corner. May I request that you allow it to connect as a call to access to your microphone, that headset, because now you are not audible and you have not joined with your microphone. Push, yeah? Okay. While we are still waiting for Portia to do that, meantime, may I welcome everyone to this session and encourage you to keep your microphones on mute unless you are requested to say something. Today we are having our session on matching the drug class with pain. Last week we were looking at the patient factors that influence prescription of an analgesic, and our guest lecturer was Mr. William Villa. And even today we also have our guest lecturer to take us through on how we match a drug class with the pain. And we also will have our case presenter from RFM Hospital Palliative Care Unit, which will be presented by Nonsikelo Lontuli. For this time, may I request that I give this opportunity to Mr. Villa to share his presentation. Mr. Villa, may I give you this opportunity to share your presentation, sir?
Thank you so much, Chair. Thank you so much, Mr. Mahlangu. May I once again greet all of you colleagues. I'll be presenting on the WHO pain ladder under the topic that says matching drug class to pain. The objectives of our lesson today, we want to define pain and also to discuss the WHO pain relief ladder, like I've already said. Then we will then discuss or classify the commonly used analgesics and discuss their doses. So basically that is what we are going to present today. Then after that we'll have questions and discussions. What is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. That is a definition by the International Association for the Study of Pain, MACSE 1979. So like we always know that pain is subjective, so you have to listen to what the patient says. Then if the patient says it's severe pain, then take it as severe pain, or it's mild pain, take it as mild pain. So the patient self-report of pain is the single most reliable indicator of pain. So as clinicians, we must accept that. So, and then we are then going to remind ourselves briefly. We did that in the previous sessions, where we know the tools that we use for for evaluating pain or for assessing pain. So after assessing your pain, you should know whether it is mild, moderate, or severe. So today we're going to concentrate after assessing the pain. What drugs do you give? And what tools are assisting you, or they should assist you to measure or to give the drugs according to the measure of the pain that you have. So let us continue. So the things that you should consider when you are matching drug class to pain, the assessment, yes, and then you select the minimum safe and effective medication for treating the pain. Then you select the medication class that matches the patient's pain type and pattern. Then you refine the drug choice according to what the patient is reporting. Is the patient benefiting? And you also watch for side effects, and you should also know your drugs, the risks of each drug class, the contraindications. Some contraindications, of course, are not absolute. So you should weigh the benefits versus the risks. So the pain ladder itself is as follows. So for mild to moderate pain, you give that's step one. You should give a non-opioid. Paracetamol, your aspirin, and your NSAIDs. Those are non-steroidal analgesics. These ones, of course, they also have, we will discuss later on. So you can give paracetamol, for example, together with an NSAID diclofenac, if there is a need, or you can give paracetamol alone. So these are non-opioids in step one. So, but in step two, you for moderate to severe pain, you give a mild opioid like codeine, tramadol, with a non-opioid, which means you can also give a paracetamol or an NSAID. Then in step three, you give a strong opioid. In palliative care, we like morphine. We give morphine. You can give meperidine or pethidine. You can give fentanyl or alfentanil, any opioid, strong opioid that you know of that is suitable for the patient at that time, and together with a non-opioid. So that is now. So now looking at the pain ladder in detail, if you can look at the next ladder. So for step one, the non-opioid, I said it's paracetamol, aspirin. You can also give an adjuvant. So it's a non-opioid plus an adjuvant. Adjuvants are drugs that are going to assist, they assist us in managing the pain, in making the analgesia or analgesic drug to be more effective. Sometimes the adjuvants are given on their own, and they do assist in combating pain on their own. So we'll discuss about adjuvants later in the following slides, so that we know what types of adjuvants we normally give for pain relief. So if pain is not controlled in step one analgesics, move to step two by adding a weak opioid. So weak opioid, I said, are for moderate pain, like codeine, tramadol, and the like. So you also give a non-opioid, and you give an adjuvant as well, whenever it's necessary. If an opioid for mild or moderate pain has been used to a maximum dose and the patient still has pain, then move to step three by changing to a strong opioid. So I said strong opioids are morphine, pethidine, fentanyl, and the like. You still give the non-opioid and an adjuvant to relieve pain. So next slide. If we look at the next slide here. So here we are discussing in detail what are the doses or how do we give these drugs. In the step 1 drugs, the non-opioid, the most common drug that we use is paracetamol, which is safe even in children who are less than a year. So there, like we normally say, in children, we give per kg body weight. Of course, in all patients, you should give per kg body weight, but you should be very, very careful in children. So it's 10 to 15 milligrams per kg, 6 hourly, or you can even give 8 hourly in children. So 1 to 5 years, it's still the same per kg body weight. Then now in adults, it's 15, if you calculate that, it's still 10 to 15 milligrams per body weight. That is 500 to 1 gram PO 6 hourly. But be careful, the maximum dose should not exceed 4 grams. 4 grams. So because we are worried about hepatotoxicity, which can occur if you exceed the maximum dose per day. So paracetamol can be combined with a non-steroidal anti-inflammatory drug like diclofenac or and the like. So next slide, please. So here, ibuprofen is one of the NSAIDs that we chose to talk about here. In children, the dose there, it's 5 milligrams per kg, 6 hourly, or you can even go 8 hourly. So the maximum dose there is 30 milligrams per kg per day in the divided doses of 6 hourly or 8 hourly. So the adult dose is 400 milligrams 6 hourly. We are used to prescribe ibuprofen 400 TID. So that's but the maximum dose there is 1.2 grams per day, a day. So you give with food to avoid this gastritis, and also you should give it with precaution in asthmatic patients. So to counteract the GI tract irritation, you should also give it with a proton pump inhibitor like omeprazole. In the past, we used to have ranitidine and cimetidine, but we no longer have those now. So you give omeprazole as well. So next slide, please. For diclofenac, these are the doses. So that one is 50 milligrams TID for adults. So remember, we like to give our drugs POs, yes. So you also give food to avoid, the GI tract irritation. Next slide, please. So we codeine, those are the doses. And for infants, the safety is not established. So we give for children over 6 months, 0.5 to 1 milligrams per kg. 2 to 6 years, 1 to 1.5 milligrams per kg, divided 4 hourly or 6 hourly, but we should not exceed 30 milligrams. Then in adults, you give 30 to 60 milligrams 4 hourly. So like we said that we should combine these drugs in step 2 with those drugs in step 1 and the adjuvants. Next slide, please. Tramadol, those are the doses for tramadol, 1 to 2 milligrams per kg, and still in children less than 16 years, you shouldn't give. The safety has not been established. So in adults, it's 50 to 100 milligrams. That's the usual dose. PO 4 to 6 hourly, or even IM is still the same dose. You should start with a regular small dose and increase. If there's no response, the limit dose is 400 milligrams per day. So that's it. Next slide. Then for step 3, strong opioids in children who are opioid naive, or those are infants less than 6 months. The starting dose is 0.02 milligrams per kg for morphine, and for those more than 6 months, the starting dose is 0.04 milligrams per kg of hourly. We know that the normal dose for adult is 0.15 to 0.03 milligrams per kg. That is the IV and IM dose. But we know that the correct morphine dose is the dose that relieves the pain. So you escalate the morphine dose until you reach where your patient is relieved. That is when you then decide to reduce. For fentanyl, the dose there is 1 to 2 micrograms per kg body weight. Fentanyl is a very potent opioid, so it's given in micrograms. So it's 1.2 micrograms. The maximum that you give at a time is 100 micrograms if you want to relieve acute pain. So next slide, please. So assessment is mandatory, like I said earlier on, and should be reviewed. You should assess your patient now and again. Don't use the results of the first assessment. So you should reevaluate your patient periodically. So the oral form is preferred whenever it's possible, but of course sometimes our patients are unconscious. Then we can try the rectal. You can even try other means. We always try to avoid inflicting pain in our patients. Analgesia should be given regularly, not on demand. There is no PRN analgesia, especially in palliative care. So you should give it until the pain is relieved, and then you give regular doses. So, and always, when we say there is no standardized dose, we say you should always increase your dose until you reach, if where there is a ceiling dose, you reach, and then you change your drug according to the steps. So adjuvant treatment should be added whenever possible. So next slide. These are we want to discuss adjuvants now. There are medications that are used to relieve pain through other mechanisms. So, and they are particularly useful in pain. If pain is only partially sensitive to opioids. For instance, neuropathic pain, you can give whatever opioid but the patient will still be complaining of pain. Bone pain is also another stubborn pain that doesn't go away easily. Smooth or skeletal muscle spasms, and the pain related to anxiety. So the use of adjuvants alone or in conjunction with step 1 or 2, 3 analgesic is recommended. So next slide. So here are the adjuvants that we normally give with analgesics. They enhance the effect of the analgesics, or sometimes they are given alone. Antidepressants, sometimes the patient may be feeling pain, and pain causes anxiety. Anticonvulsants, sometimes you need to give benzodiazepines for your patients who are anxious. Local anesthetics like lignocaine, corticosteroids like prednisolone and hydrocortisone, biophosphonates, muscle relaxants, and even other sedatives that you can think of, yes. Proper pain management is understood to be a fundamental human right and an integral to the ethical, patient-centered, and cost-effective practice in modern medicine. We all want that smile from our patients. So when they are constantly crying and complaining and in anguish, so we should do our best to treat our patients and enhance the quality of life. So the mechanism of acute and chronic pain is complex. Like, you know, the pain pathway, it has many receptors for the pain, and it's often longer lasting than expected. We expect people to be in pain for a short time, but to find out that the acute pain that we thought was acute pain now becomes chronic pain. So an early aggressive multimodal approach is what we are recommending. And we should balance that approach and provide optimum pain control with at least very little or even none side effects. That's why you should choose your drugs carefully according to your patient. Yes. Thank you very much. That's the end of my presentation. I can welcome additions and also questions. Then the discussions should follow. Thank you very much.
Thank you so much, Mr. Vida, for such a wonderful presentation. We can clear hands for him. Thank you so much. What I can say I picked from the presentation is that thorough assessment is key before we can think of using any medication to control the pain. So also when we are prescribing pain medication, we need to prioritize PO medication, especially for palliation, and also that palliative care medications, especially pain medications, are not supposed to be given PRN. They should be given on regular schedule so we can achieve an effective pain control. And also, he also mentioned that there is no standard dose, but you always titrate or prescribe the pain according to the patient needs. And he also mentioned that some of the pain may be stubborn, so that's why we combine all the three ladders with adjuvants. He also mentioned that we can combine step 1 with the other step 2 drugs, but we cannot combine the 2 opioids, which is a weak opioid and a strong opioid. But then the non-opioids can be added with the opioid plus adjuvant. He also mentioned that there are things that we need to consider, which is assessment, and then we always select a drug with minimum side effects, and that is so effective in treating the pain. So we also look for medications that matches the patient type of pain, and then always we need to refine the drug choice, looking at the benefits and effects and the risk of such a drugs. So that's what I can say. I don't know, but if anyone with a question for Mr. Villa or any addition to add on such a wonderful presentation, may I give the opportunity. Anyone with a question for Mr. Villa concerning matching the drug class or the pain?
Thank you so much, Chair. I know they are still consulting their notes, or maybe they are still discussing among themselves, participants. May I also add that according to the Southern National Guidelines for Children's Palliative Care, it's a book that I have on my desk here. If you open to page 31, For children, it's always recommended that you, from step 1, your step 2 should be strong opioids and the non-opioid and adjuvants, which means you jump step 2 to step 3 if you follow the WHO step ladder. So their step 2 is what is commonly known as step 3 in the normal ladder. Why do we do that? Most of the drugs in step 2, you find that especially the opioids, their safety is not like I was presenting. Their safety is not established in children. So you simply go for your drugs in step 3 in order to relieve severe pain. Thank you very much.
Thank you so much, Mr. Mvila, for the clarity. Mr. Mvila emphasizing that for children, we don't give step 2 drugs, which is tramadol codeine. We don't, so they are not safe for the children. So for their step 2, we just move from, for example, from Panadol straight to morphine if the pain is showing to be not well controlled by step 1 drugs, after we have tried to combine them with adjuvants and other stuff for the child. So we can move straight to morphine, which means children deserve and have the right to access strong opioids. Anyone with a comment? Or Margaret Gametz on chat has said, thank you, Mr. Mvila, for your clear presentation. That's from Margaret Gametz's comment for you, Mr. Mvila. Anyone with a comment or question on addition? Okay. If there is no comment, thank you so much, Mr. Mvila. I hope you will also assist in this case presentation. We can now move towards our case presentation. We have our sister Nurse Nduli from RFM Hospital Palliative Care, who will present the case for today's session. Nurse Nduli, are you available?
Yes.
Okay, maybe before we can start, I see Zishe asking if you can get the presentation. That's now you are all registered in the ECHO platform. Presentations after this session will be uploaded into the platform. You will have access to them 24/7. So don't worry about them, the presentations and all things that you need to have access to concerning the materials and everything will be available for you in the platform. So don't worry, even the video of this session will be available in YouTube. So we'll provide you with the access link to that YouTube, ECHO-Eswatini Hospice. So all materials that you have made to these sessions will be available for you. Thank you, Zit. I think I've responded to your concern. May I give Nduli this time to present the case?
Afternoon, colleagues. I'll be presenting my case of a patient who is 71 years old. The follow-up client is a female. Diagnosis: patient have cervical cancer. What is the main problem or concern about the client? Problem: client is passing black stools and vomiting with everything she eats. Concern: cancer might have spread to other body organs and she can no longer go back to South Africa for further assessment because of financial constraints. Chief complaints: severe epigastric pain, lower abdominal pain, passing loose black stools, vomiting and dizziness. On assessment, client is sick looking with some dehydration. Pain assessment. Pain 1, it was assessed when the client was enrolled on palliative care. Patient said the pain is chronic, it's burning. Scale, it's 4/5. Periodicity is intermittent. Precipitating factors, movement, and after meals. Relieving factors, sitting position, and pain medication. Her pain affects her sleep and mobility. The pain medication, it's helping, but partially. Pain 2, pain is chronic and it's stabbing. Scale, it's 3/5. Pain is now constant. Precipitating factors, it's movement. She gets relief by sleeping and having pain medication. She also has problem in sleeping and being mobile. Effect of current medication, it's partial. Pain evaluation form. 25 October 2022. Pain location is on the abdomen. Scale is 5/5. Intensity is overwhelming. Duration, the pain has lasted for more than 20 years. Possible cause, it's activity. Treatment, it's morphine and omeprazole. 24 November 2022, the patient reported that pain is on the abdomen. Scale is 4/5. Intensity, it's severe. Duration of the pain, it's 6 days. Possible cause, it's activity. Treatment is it's morphine 30 milligrams orally 2 times a day, omeprazole 20 milligrams orally twice a day. Progress following intervention. Patient reported that when she is able to take the medication, it really helps. But the past 6 days, she was not able to take anything because of the vomiting and the diarrhea. Medical history. Patient was enrolled on palliative care 25 October 2022, presented with severe LLPs, poor appetite. Patient is a known hypertensive client on treatment, has been recently diagnosed with corrosive gastritis. In 1997, she was diagnosed with cervical cancer, did hysterectomy the same year and undergo chemotherapy in year 2000 in South Africa. Current medication, patient is on enalapril 10 milligrams orally for two times a day, morphine 30 milligrams orally 2 times a day, bisacodyl 5 milligrams orally, Nocte, Panado 1 gram 3 times a day orally, HCTZ 25 milligrams once daily. Social history and pertinent family history. Client is a patient here. Socio-economic class is middle class. She's singing. There are no unhealthy lifestyle habits. There is no known relevant health condition in close family members. Advanced directives, orders, DNI orders, no. Living will, no. Advanced decision to refuse treatment, none. Healthcare proxy, it's her daughter. Mental capacities, the client is mentally stable. Review of systems, temperature 35.3 degrees Celsius, BP is 150/84, pulse 62 beats per minute, respiration is 18 breaths per minute, saturation is 98%, pain score it's 4/5. ECOG functionality score is 1. Other symptoms, pain, it's severe, there is no dyspnea, there is mild anxiety, there is no agitation, there is no depression, it's moderate, has moderate drowsiness and fatigue, has mild nausea and vomiting, anorexia, there is none, constipation, none, dry mouth, none, poor mobility, the patient is mobile. Further plan, doctor ordered ringer's lactate 1 liter intravenously to run slowly and flagyl 500 milligrams IV stat. Patient was advised to take small frequent meals. Thank you.
Thank you, Ms. Julie, for such a presentation of that patient. Who is a 71-year-old woman with history of cervical cancer. However, not yet told at what stage now it is, but we are seeing that the patient is now passing blood stools. There is a concern that the cancer might have spread to other body organs and she can no longer go back to South Africa for further assessment because of financial constraint. So the patient has been experiencing severe epigastric pain with lower abdominal pain and vomiting and dizziness. So I can see people on chat say something, but I will give this opportunity for you participants to share something. Anyone to comment or have a question for Sis Nesturi concerning the page, or to help address the concern that they have here that the patient is pushing black stools and there's a possibility that the cancer has been metastasized, and then there is a pain that is partially controlled and the patient is on morphine. Oh, I see Tani here has something to say.
Good evening, good afternoon once again, colleagues. My question to our colleague would be to ask if any investigations were done to find the main cause of the gastrointestinal bleeding, since the indication with the black stools, it means the patient is having a GI bleed. And also if the HB levels of the client were ascertained, And also with the medication, I'm not sure if I saw well, but with a client who's been having this serious type of bleeding, is the client getting any supplements like ferrous and folic to at least help with the HB since she's having this GI bleeding and also with the cancer? Thank you.
Okay, thank you, Ms. Kani, for that comment. I hope Nancy has also got it.
Okay, colleague. Okay, concerning the investigation, we have not yet done anything to investigate on the gastritis. Maybe I will try advocate for the patient to the doctor, because mostly it's them who refer for further investigations for the patient, so that concerning the gastritis.
Yes, Mane, we lost you. May you repeat what you were saying?
Hello, you can hear me now?
Yes, can you repeat what you said?
Oh, okay. Concerning the investigation, we have not yet done anything to investigate further concerning the gastritis. Okay, the HB, they also didn't check the HB of the client. Yes, and again, what else? Okay, when I look also at the last orders of the client, I don't see the supplements here. Maybe I will also advocate for the client to be given the supplements.
Okay. Thank you.
I think.
Yes, Sister Felicity has an advice for you on chat. He's saying advise patient to take blend diet.
Blend diet.
Yes, blend diet. He's advising that the patient must be advised to take blend diet to curb the vomit.
Oh, okay. Yeah. Thank you very much, sister.
Anyone to help Manzini? A few comments here, Mr. Mvila. I hope you are still there. I have comments that pertains the presentations. Sister Felicity commented and said, thank you so much, sir, for the step. When in step 3 analgesic, the pain is subsiding, the narcotic is stopped and gradually and step back to previous steps. So you gradually step down or withdraw opioids. You don't just take them once off. And Portia asked a question, I think Mr. Mvula, you can respond very well for this one. He says, how serious is the issue of addiction to opioids? Mr. Mvula, are you still there?
Yes, I'm still there. Yes. Yes. Opioids, when you want to talk about addiction, it is a concern for most healthcare workers that the patient may be addicted. But most patients who are addicted to opioids are those who are abusing opioids for recreational use, like they feel good feeling that they have after getting an opioid. But when an opioid is given by a health professional and it's controlled, there are very, very few cases of addiction that are reported. And of course, like we said, you titrate upwards and downwards. The opioids, be careful when you prescribe. That's why there is the prescription for opioids is carefully monitored. Be careful when you prescribe opioids, and then be able to support your patient when you feel the patient now needs more. That's why we also said health assessment. But don't be afraid to give an opioid just because you think the patient will be addicted. Just make sure that you give an opioid and relieve pain. And once the pain is relieved, then you'll be seeing a smile on the patient's face, and you'll be happy yourself as a healthcare worker. Thank you very much.
Thank you, Mr. Mvila. Portia, did Mr. Mvila attend your concern?
Yes, thank you. I'm answered.
Thank you. Okay. I've seen that your client is on morphine 30 milligram, and it is not effectively controlling the pain, and it is said that the pain is still at a 4 out of 5 and sometimes 5 out of 5, and it's partially controlled. So what plan has been in place to at least move it to full control? See? Hello, did you get the question?
No, I didn't get it.
Yes, I was asking that your patient...
Can you please?
Yes, I was saying your patient is currently on morphine. I believe it's the MST, which is PD. However, the patient's pain is not well controlled, it's partial. So I don't know if there are any means, or in your deep assessment, what could be leading the pain to be partially controlled, or are there any means to completely control the pain?
Oh, okay. Unfortunately, here at RFM, I may not say what exactly is happening, but because they give the tablets, they don't prescribe more than the 30 milligrams PD. And I cannot say what exactly is the reason to do that. We then maybe add up paracetamol or paracodeine so that the pain medication, maybe they will be effective for the client.
Okay.
Yes.
Okay. Yes, I see some other comments on chat. Sister Felicity is saying strengthen supportive care for the patient, and thank the patient for being strong and fighting cancer over the past many years. It has been years. And then do stool culture and the endoscopy for gastritis. Patient might need to involve, you might need to involve surgical team, and the antacid stronger than omeprazole or Mygel will help relieve the pain. I don't know if you are getting Sister Felicity's comment, Ziggy.
Yes. Thank you very much, sister.
Yes. Also, we have a question from Tandazile who's saying, What would you say about the use of stool pushers alone when using morphine? I think the team can respond. What are we saying about the use of stool pushers alone when using morphine? Our patient here is using morphine, and then he's using Pesacodil only, which is our stool pusher. So Tandazile is asking, what are we saying about the use of stool pushers only? Normally, when you are taking morphine and there is a possibility that you are constipated, in morphine, we recommend that we combine the two laxatives, which is a stool softener and a stool pusher, which is normally it can be lactulose and together with Bisacodil or Senna, or it can be lipid paraffin or castor oil together with Bisacodil or Senna, because the Bisacodil is a stimulant. It stimulates the gastric motility, which was related by the morphine, and then it makes it go faster. But if then the patient was already constipated, then what will happen is the gastric motility would be increased, and it will push this hard stool that is already in the colon. And then what will happen then, you will discover that some patients in the long run of taking morphine and the stool push alone, they develop piles. So then you will find that a cancer patient now has developed piles because he was pushing this hard stone through the anus. So it's not recommended. So we normally say combine the two. We know we usually encourage them. Now we are taking morphine, take more water. But in reality, on real life, how many liters do you take a day? That one is not going to work sometimes. So we need to really assess, and then we need to combine the two. It helps to do that. Even if the vomit is there, we also need to verify. Constipation is not there. And morphine is a serious cause of constipation if not well managed, because it can lead to fecal infection. Once there's fecal infection, then that's a disaster. So we need to manage that one very well. So another thing to add on what Mr. Mvila said concerning opioid addiction. You know, in the facility, sometimes we are tempted to combine the weak opioids and the strong opioids. If not us, the patients themselves, they combine them. They will take tramadol or codeine, and then they will take morphine. And then they will sometimes break up loose and say to you as a healthcare worker, you know, if you can give me the tramadol together with the morphine, I will feel better. That one works very well for me. And if you know very well, that one is a sign that now this patient has been addicted to one of these opioids. Because what happens is there's only one opioid receptor that these two compete to act on. So if morphine has been absorbed and reached the receptors first, then the tramadol will float and go to the addiction center. And then the patient will be addicted and feel high and feel nice because it's combined. So that's why we have to be very cautious when we're prescribing opioids. Don't combine the two. Sometimes they go to home, and then we've prescribed some TTO, they go home. If then you want to change from either morphine to tramadol or prescribe either, you need to ask the patient if there's still some tablets left at home. Because if they are there, they will combine the two. And later they will then become addicted to one of the drugs because you combine these two opioids. So we recommend not to combine them because combination of them pushes the patient towards addiction. I see Sister Felicity also adding here, saying also encourage hyper diet, increase fluid intake, and also home remedies, which include crash purposes, and also any food that stimulates passing of stools. So even if we not rely on the medical or the Western medicine, we have our own, the purple seed and the other things that we can do. And also the ECHO-Eswatini is also added that you can also use the psyllium husk as a stool stimulant. So there are many things we can use to relieve the constipation. So what else can we say here? How best they can manage such a patient? I think also you need to dig down into the assessment in terms of how effective is the pay, is the MST working for the patient. In terms of the patient, where is the pain being experienced between the two doses? You know, maybe the patient will say the pain comes 6 hours later, then will advocate for the liquid one, so that then the patient can go for that until the pain is standardized or is stable, or is well controlled. Then we can now think of going to the MST. So I think that one needs to be reviewed. And also, Sister Felicity is saying that high dose of morphine needs to increase the high dose of laxative. So the more you increase morphine, you need to also increase the laxative. Also, the functionality status of the patient determine how much laxative you're going to give, especially a bedridden patient, other than the morphine constipating, the fact that motility is being reduced, they can also do that. I see a comment from Sister Mbata. He's saying, thanks for the presentation. I want to ask, if does the non-pharmacological pain management and diet to assist, okay. Let me read it very well. I want to ask, if does the non-pharmacological pain management and diet to assist in reducing the pain complications such as constipation, fecal infection, helps the patient? That's the question for us all. Sister that is asking if the non-pharmacological pain management and diet assist in reducing the complications such as constipation and fecal infection for the patient. So does that one works? Anyone to respond to Sister Mbata's question? Does the non-pharmacological and the diet assist in reducing the complications like constipation and impaction? Yes, Tammy has a response for you, sister.
Good evening once again, colleagues. I think it does help a lot, especially for the non-pharmacological pain management. I do have a client who has cancer, but she does not want to use any form of medication for the pain management. So right now she only uses the non-pharmacological management, which most of the time she does yoga and some relaxing exercises, and she reports that it does help her a lot. And also with the diet helps a lot with prevention or with management of constipation and fecal infection.
Yes. Thank you so much. In one of the sessions around 31 May, and around May, we will be covering the non-pharmacological, but even the dietary ones. We will see which food we can encourage our patients to control the side effects or the complication like constipation, eating fiber diet, you know, doing some exercises, motility, but some of the patients does not work because really they are not mobile itself, but non-pharmacological, they help a lot in reducing that. I don't know if there's another question. Okay. So another thing, can we add anything for management of this patient? Or any comment you want to add? Okay. Another thing I will. Okay, Sister Felicity is saying manual fecal evacuated. I don't know, Sister, what I say. Maybe you are saying manually removing the stool, right, Sister? Which also that one can help. Okay. Anyone else? Oh yes, Sister is saying also you can manually remove the stool, you know, if it's already clogged there, you can manually remove the stool. That's another way you can deal with the stool there. Anyone who may want to add for this patient? Yes. Tanya, something to add?
I think also educating the client on top of what mainly Sister Felicity has said, inclusive of the diet and the medication, using both stool softeners and push-downs. You can also encourage the clients to not resist the urge to go to the toilet. Immediately, it says he must go to the toilet, the patient should do so, because the longer the toileting is postponed, more water gets absorbed from the colon, resulting in harder stools, and also to encourage the client not to spend prolonged time in the toilet, because whilst sitting in that position, toileting position, the veins on the anus, they get engorged with blood. So that blood takes a long time to go back to be reoxygenated in the heart. So you find that the client now has this engorged vein on their anus. The next time they pass a stool, and you might find that most of the time it's a hard stool, it is the one that bruises the vein and results in bleeding. Then we say the client has hives, or what we call hemorrhoids. I think that's all.
Thank you. So Scan is encouraging that if the patient is the age to train, we encourage them to do so. And this one is a very that you are already, you know, age factor in GI motility is already a factor. Sister Felicity is also giving the advice that the patient have seen that sometimes have nausea and diarrhea. So Sister is encouraging that we need to withhold laxatives when there is diarrhea, and then we continue with the morphine so that we are on the side effects of morphine, of constipation, then we'll stop the diarrhea. So thank you so much, Sister. I hope Nsiki is also picking that point too, that when there is diarrhea, stop laxatives. Sometimes even educating the patient, because you will not be there when she's experiencing that. Whenever you are experiencing loose stools, don't take laxatives. Withhold them until the water stool stops or the loose stools are stopped. And then you can then continue later. And then the patient, I think also, we need them to also focus on the issue of the age, and also find out what the patient feels, what are the fears of the patient, what the patient perception of the condition. I saw that one of the concerns here is that as clinicians, we are suspecting that maybe the cancer is relapsed or has come again, and now it has spread to other organs. Maybe even in the stomach, it is there already. But then we need to also assess the patient's concerns concerning the diagnosis and concerning what she is experiencing. That also will help us to allay the anxiety that comes with the experience of cancer and the experience of what is happening. And currently the patient is experiencing financial constraints. So we need to also assess how does that affect the patient spiritually And at 71-year-old, we know by this time we discover that the patients already have family relatives who are taking care of the caregiver. I think also harnessing on family support will be so important at this stage in time, while we are still doing the investigations on what could be the cause of these stools having blood. So I think also that one, and also building on, as Sister has supported, that we need to strengthen psychosocial support for this patient and elderly. At this time, we discover that other treatment will not be feasible. So we need to start as early as possible, discussing the goals of care with the patient. I don't know anyone who wants to add. Maybe before we can close the session, anyone who wants to add? Okay. If there's no one who wants to add something, I think this is our presentation today. We have learned about the importance of assessment and the importance of matching the drug class with the pain. And also we have seen the patient from RFN. Our next session will be on the 14th of December. And on the 14th, we are from this month, we are treating the bigger topic, which is pharmacological and non-pharmacological pain management. You can visit our platform or the website to see the session that are gonna come. So in our next session, we will be assessing the risk for opioid substance use disorder. And we will have it on the 14th of December. After that, we will have a break, and then we will come back on the 20th. We will come back on the 11th of January for another session. So our last session for this year will be on the 14th of December. May we encourage you all to click on the link provided on chat, so you can be able to share your feedback, and we will encourage you to attend all the sessions as possible as you can, so that by the end of 26 July, you will be able to receive your certificate of attending pharmacological and non-pharmacological management of pain. So if you attend all the sessions, you are increasing the chances that you will get the certificate. So we encourage all of us to attend the session so we can get those certificates. Thank you so much. May God bless you all. While you're exiting, please click on the feedback link shared on chat, please. Thank you. Bye-bye, everyone. Bye-bye, Ziggy. Bye-bye, everyone.